Welcome to this Medscape podcast. I'm Benjamin Levy. I'm a gastroenterologist at the University of Chicago, and we were super excited to feature gastroenterologist Darren Brenner from Northwestern with us today. Many of us in Chicago consider you the constipation guru, and know that you treat some of the most severe constipation patients in our area. During this podcast today, I hope to share some of your clinical knowledge and experience with listeners, gastroenterologists, primary care physicians, and of course, patients too. Could you tell us about your gastroenterology clinic at Northwestern and your focus on constipation? I'm really excited to learn more about your work on constipation, IBS, and motility at Northwestern University.
So first, Ben, thanks for having me. It's really an honor to do this, and I'll be happy to make a shameless plug for our program at Northwestern. At Northwestern, we run an interdisciplinary constipation program. It's just not me. It's my junior faculty, my PAs, my nurses, but also our dietitians and behavioral psychologists, because I think in 2025, we have to start to understand that there is more to constipation than just pooping on a regular basis. And it really does take a team to get patients better. We have a physiology lab that we use at Northwestern where we run specific tests for constipation, specifically tests for pelvic floor dysfunction like anal rectal manometry and balloon expulsion testing. We run breath testing for people that are concerned about intestinal overgrowth playing a role in their constipation. And hopefully, again, soon, once the technology is back, motility testing to look at delays, not only in the colon, but the entire GI tract. It's a program that I've been involved in now for about the last 18 to 20 years. And like you mentioned, we see the gamut of patients, people with simple, just slow transit constipation where things move slowly through the GI tract to complicated irritable bowel syndrome and individuals with pelvic floor dysfunction. And in many cases, an overlap between many of these different types of disorders.
That's awesome. And it sounds like it's super well organized. So let's get into it with some questions that I think a lot of gastroenterologists and patients will be curious to hear how you think about approaches to patient care. So in a 2021 systemic review and meta-analysis published in The Lancet, approximately 1 in 10 people globally experience functional constipation using the Rome 4 criteria. And chronic idiopathic constipation affects approximately 9 to 20% of adults in the United States. Also, a 2020 study published in the American Journal of Gastroenterology found that 3 out of 5 Americans with constipation have never discussed their symptoms with a physician or healthcare provider. Now, some of these patients are using over-the-counter approaches with success, while others are suffering through their partially treated constipation. How would you define constipation? And are there certain questions that you ask patients who present to your clinic with constipation when you first meet them?
I think what we've learned from those studies is that poo is taboo, right? People just don't like to talk about this process. It's something that has been always defined as icky, but the issue is that it is very common. As you mentioned, multiple studies around the world have shown that the prevalence is like 10%. So it's 1 in every 10 individuals. And I like to put this into terms people can think of. Think about Soldier Field. What does it hold? 60,000 people? That means that within that stadium on any given Sunday, about 6,000 people probably suffer from constipation. So how far do you have to actually look or move your neck or crane your neck to see somebody with constipation? It's a very common disorder. Now, this is one of those disorders where I think that the Rome criteria get it absolutely right. And that's probably part of the reason why over the last 30 plus years, the criteria have not changed. Because the reality of the situation is that constipation means something different to everybody. For some people, it means I don't poop enough. And normal in the United States is anywhere between 3 times a day to 3 times a week. To other people, it means I pass hard stools. To practitioners, we ask about straining, sensations of incomplete evacuation, feelings of mechanical obstruction, and then the gross questions, right? Do you perform manual maneuvers? Do you manually disimpact or put your finger in the bottom to pick stool out? Do you splint? For women, this is putting a finger or two into the vagina and pushing posteriorly, which will normalize anatomical defects. And nowadays, we should be asking about posture modifying devices, things like step stools or squatty potties that change the physiologic parameters of the pelvic floor and can make it easier for people to go to the bathroom. So I ask all those criteria, and I want to know about all those criteria. But there are two things that I think that many of us miss that we should be addressing on a regular basis. Number one, we need to get better at asking questions about trauma, PTSD, physical, sexual, and emotional abuse. These types of things link very closely to the development or worsening of chronic constipation or irritable bowel syndrome with constipation. The other thing we have to do is we have to stop thinking about irritable bowel syndrome with constipation and chronic constipation as separate entities. Because the reality of the situation is, as you mentioned in the literature, anywhere between a half to three quarters of patients with chronic constipation will endorse abdominal symptoms like pain, discomfort, and bloating. And these patients have been historically just thrown into the irritable bowel pool, but there's a big overlap in that. You also mentioned that a lot of these patients don't mention it to their practitioner. They try the over the counters. When do they actually come to see people like you and me? The data would show that they come to see people like you and me when their abdominal symptoms are pervasive and still present, when laxatives have failed to improve them. So the laxatives, the over-the-counter laxatives for the average individual will improve the bowel symptoms we just talked about. Frequency, texture, straining, incomplete evacuation, but they do nothing for abdominal symptoms. So I beg my colleagues in practice, and I ask our patients too, when you see your practitioner for constipation, mention the abdominal symptoms that you're experiencing, because that could potentially change the diagnostics that we want to run and the therapeutics that we recommend.
Those are all fabulous points. And I think that we really should be personalizing our questions more and getting a good social history for them, especially screen for any trauma. And I was recently at one of the American College of Gastroenterology meetings, and one of the speakers was talking about that. So I think that we're really trying to educate gastroenterologists nationally about that. So the next question I wanted to ask you is, what criteria do you use to determine whether a patient is experiencing constipation or IBS constipation? I know that we want to treat both, but could you give us a little bit of guidance for the general gastroenterologist?
I will be honest, I don't really look at these as two separate entities. I look at them as a spectrum disorder, and I define them more so based on the severity of the pain itself. As I just mentioned, the vast majority of individuals with constipation have abdominal symptoms. And many of the treatments that we have, specifically the prescription medications, the FDA approved medications, are approved for both constipation and irritable bowel syndrome with constipation. On the flip side, none of the over the counter therapies that we use on a regular basis have been ever approved for irritable bowel syndrome with constipation, and there's minimal data to support. So, here's how I try to differentiate in my head if I have to. If I'm really under the gun, somebody says you must make a specific diagnosis. If a patient walks in with bowel symptoms and no abdominal symptoms, it's not irritable bowel syndrome. Remember, the sine qua non of irritable bowel syndrome is abdominal pain, and really in clinical practice, discomfort, bloating, the overlapping symptoms we talk about on a regular basis. If somebody comes in with both, then I will ask, what is the pervasive symptom? If somebody says, I have pain all the time, and then I have a bowel movement, and that improves my pain a bit, but only for a short period of time, a few hours till I eat next, those sorts of things, that more fits along the spectrum of irritable bowel syndrome. If somebody says I go 5, 6, 7, 10, 14, 21 days without a bowel movement, and the longer I go, the worse my abdominal symptoms get. But when I finally evacuate, the symptoms go away and I'm clean and I feel empty, and then the process starts all over again, that I will lend more towards being on the chronic idiopathic or functional constipation side of the spectrum.
Thanks for clarifying that. So, what are some of your initial strategy treatments for constipation? And do you focus on over the counter medications before escalating to prescription? I imagine, like our practice here, by the time a physician actually gets to a gastroenterologist, they've frequently already tried some over the counter stuff and have already talked to their PCP. But what are some of your strategies?
Yeah, so again, it depends on whether or not there's an abdominal component. If there's no abdominal component, I start with the over-the-counter therapies. And I know there's a debate, and the studies show that we use either PEG 3350 or soluble fiber as a first-line intervention. The clinical data would suggest from head-to-head trials that the PEG 3350 is more effective, and systematic reviews have validated that as well. That being said, different strokes for different folks. We've both seen patients who come in and say, I will never use a laxative. I don't want a laxative. Take something else. What do you recommend? Then I go to fiber, and fiber can be supplemental, and I go to psyllium. which is a soluble fiber, or I go to food based fibers like kiwis, mangoes, prunes, chia flax seeds, and oatmeal. They have data supporting their benefits. However, where do I curve away from this? These are people that come in with the abdominal symptoms, the pain, discomfort, bloating, and distension. I am more likely then to pull the trigger on the FDA approved therapeutics because there is rigorous evidence based control trial data showing that these medications can improve those abdominal symptoms. And again, the most recent patient reported outcome studies where we've asked patients what drives you to practitioners, the answer is the abdominal symptoms. So I want to target those first because that's really what's driving people to come see us in clinical practice. Now, let's say, like you said, we both work at tertiary quaternary centers. We see these patients and the patient has failed the over the counters. Where do we go at that point? Then at that point, I'm bringing these patients into my physiology lab for anorectal manometry balloon expulsion testing. Because at that point, my concern is that the problem is in the pelvic floor, and the pelvic floor is the rate limiting step. I always tell my patients this: your GI tract is a tube, and at the bottom of the tube, you have a door. And it doesn't matter if I can push things through your tube down to the door in 5 seconds or 5 days. If the door at the bottom doesn't open, nothing is coming out. And the treatment for the door, we may get into this a little bit later, I don't want to tangent too much, is not laxatives. You can't move a skeletal muscle with a laxative. It's physical therapy and biofeedback. So I go to that very quickly when people come to my office and say, I've tried X number of therapies, they're not working. What is going on? Then I go back to the diagnostic algorithm, not the treatment process.
That is a great description. And I think that we should be talking with patients like that. Thank you for sharing that with our audience. So, if you were to prescribe a prescription medication, we're lucky to have a plethora of available prescription constipation medications currently, ranging from secretagogues like lubiprostone, linaclotide, plecanatide, tenapanor, and the prokinetic agent calapride. Could you tell us about your thought process when selecting initial constipation medication that needs a prescription?
Yeah, it's like you said, we've got the three FDA-approved secretagogues, right? We've got the lubiprostone, the linaclotide, and plecanatide. I want to make it clear to our audience and the practitioners that tenapanor doesn't fall in that category. It falls into a category. It's a first-in-class retainagogue. It has a different mechanism of action by which it improves symptoms. And then you've got the prokinetic motegrity, which is only approved for chronic constipation, not irritable bowel syndrome with constipation. I just take a step back and say tenapanor is only approved for IBS-C and not chronic constipation. So there's a little bit there. So what I'm defining can potentially define the therapeutic that I'm going to use. My personal thought is this: I like the different mechanisms of action when it comes to treating pain. I don't see a major difference between the secretagogues and the retainagogues with respects to what they do for the bowel symptoms. They're each either pushing fluid into the intestinal lumen, increasing peristalsis, or they're blocking fluid from coming out of the intestinal lumen, increasing peristalsis. So where they differentiate from one another, the secretagogues and retainagogues, is in their mechanisms of action for pain. Prucalopride is a different beast, right? It is a serotonin receptor agonist. It goes right to the smooth muscle and says, hey, I want you to contract and push more vigorously. And I think that this is a very good therapeutic for chronic constipation. And even though it's gone generic, it can still be difficult for our patients to get. At the end of the day, the reality is when you look at the drugs for IBS-C, none have been shown to be better or worse than the others. So from my standpoint, it comes down to what I call my 4 C's. The first one is comfort. How comfortable are we prescribing the medication? How comfortable is the patient with taking the therapeutic based on its efficacy, safety, and tolerability profile? The second is compliance. Is the patient actually going to take the therapeutic? Because if they don't, it's worthless. But the reality of the situation in 2025 is that it comes down to the 2 C's that we as practitioners hate because we want to give patients the best therapeutics from our standpoint, and those are cost and coverage. Because if it isn't covered and you can't afford it, you're not going to pick it up and you're not going to use it. So that is a major issue that we deal with on a daily basis. I really can't sit here and say I have an algorithm for using these therapeutics because it really does come down to the insurance company portion of this process. And then what I think is going on is a primary issue.
Are, are there any clues that a patient may tell you when you want to use a prokinetic agent like prucalopride starting off? Because I think that's one of the hardest things we're seeing these patients, seeing how much of this is a motility problem?
Yeah, I would love to say that there's any way to differentiate these patients. The literature would suggest we take these great histories, but at the end of the day, when we use the Rome criteria, the 6 symptoms we talked about earlier, to differentiate the different constipation subtypes, they can't. They're not very effective at all. And I found that in many instances, most instances, I can't get prucalopride as a first line agent. So it becomes a second or third line therapeutic because of insurance. If I could get as a first line agent in somebody that has bloating, it's been shown to improve bloating and constipation, I would use this as a first line treatment. It doesn't have as much data for pain. So in that case, I may go to the secretagogues and the retainagogues first.
Great. Thanks for clarifying that. So, what are some patient risk factors that predispose patients to constipation? Can you go over that and ways we may be able to intervene early on, or especially primary care doctors, even just patients hearing this podcast?
It all depends on the whens and the hows. So when I see patients with constipation, the first question I ask is, when did this begin? And if somebody says in childhood, then I have a couple of concerns. Number one, did that person never learn how to potty train? Number two, was there social stigma? Was there encopresis or voluntary withholding? When the brain says poop and we override it and say, no, we don't want to, and we clench down those muscles, that can lead to secondary operant conditioning and pelvic floor dysfunction. Or number three, like we talked about earlier, was there a history of trauma or abuse? Because we know that leads towards pelvic dysfunction, which is a very specific form of constipation, or what we like to call anismus or dyssynergic defecation. If somebody says it comes on later in life, then I think about the other risk factors. We know the most common risk factor as we get older is age. Medications. People come in all the time and say, I'm not on any medications that cause constipation. But the reality of the situation is that if an individual is on 6 or more medications at any given time, even if none of those medications on their own cause constipation, that absolute number increases the risk. I look at diet. Like you said earlier, are you eating a diet that is low in fiber or more specifically soluble fibers? I look for underlying causes. What other secondary causes in medical history could be doing this? Things like hypothyroidism, diabetes, hypercalcemia. Do you have a neuromyopathic disorder like scleroderma, MS, ALS that could be playing a role here as well? Are there alarm signs or symptoms? Abdominal discomfort, unexplained weight loss, blood in the stool that makes us think about obstructive lesions like tumors that we should be thinking about. So, all of these different things come into play when I start thinking about what could be causing constipation. If there are no alarm signs or symptoms, and we don't have any prognostic factors, or we don't have any factors that were associated with the onset of the disorder, then I treat like everybody else. And again, it's most cases over the counter for functional constipation.
We definitely are seeing a lot of patients, at least in America, who are not consuming enough fiber.
For sure.
It's not infrequent, probably at least 2, 3 patients a day. When I ask them how much fiber do you eat daily, how many servings of fruit and vegetable, and they have these blank stares and it's 0 or 1. I think not just for constipation, but really to try to prevent polyps and just the overall health, we need to be encouraging people to eat a lot more fruits and vegetables in this country and to make them more easily accessible. So, this is something I also frequently hear from my patients. Sometimes they're afraid to have bowel movements at work and they hold it in all day until they get home. Unfortunately, as this allows the colon to absorb even more water, and I don't think patients realize that, making their bowel movements even harder and worsening their constipation. Do you have any tips for patients who are hesitant to have bowel movements at work? I frequently encourage them to go to a different space in the building so they don't run into people that they know. But what are some tips that you have for your patients?
Yeah, first and foremost, you're right about the whole water resorption, harder stools. But as I was mentioning a moment ago, that can also lead to pelvic floor dysfunction, which just exacerbates the problem. I tell everybody this first and foremost, like we said earlier, this is a common disorder. It's 1 in 10. And even if you don't have constipation, you're uncomfortable pooping. I tell people, look, we write kids' books, right? We have kids' books that say everybody poops, pooping for dummies. There's so much out there. Everybody does it. Don't be ashamed or don't be afraid about it. Some people want that privacy. It's absolutely fine. Like you said, I say go somewhere else. But then I try to not trivialize it, but just bring it down to a more relaxed level, right? I tell my patients, here's how I train my daughter. My daughter was in the time of Frozen. My daughter was a big Disney freak. She's now 19 in college. I used to say to my daughter, Ava, let it go. let it go. Don't hold it back anymore. We all do it. We all have to do it. It is as natural as could be. We do it from the moment we're born, right? We all, as practitioners, worry about meconium and not passing stool. We do it till the day we die. So don't be uncomfortable with the process. It's high likelihood that the person next to you is doing exactly the same thing. Just relax, let your pelvic floor relax, and don't be worried about the stigma related to having a bowel movement.
That's a great approach. Are there any labs like thyroid testing? You mentioned this in passing before. Are there any laboratory testing that you sometimes order for patients with constipation to try to see if there could be something contributing?
Yeah, the guidelines say no, but realistically, I order CBC to rule out anemia to make sure there's no complications there. I get thyroid studies and I check a calcium level. Those are the major tests that I order.
So, when do you decide to order anal rectal manometry testing? And do you sometimes send patients directly to biofeedback pelvic floor physical therapy first? Especially as you're well aware, sometimes it's really hard to get an appointment for this testing depending on what facility you're at. And patients don't want to wait 2 or 3 months. They want to have this problem solved immediately.
Yeah,
So
so
how do you decide how to think about
mhm.
that and choose which way to go first?
Like you said, both of us work at tertiary quaternary institutions. So, in the vast majority of cases, people have tried and failed multiple laxatives. And at that point, they're coming for another analysis. And if you look at the guidelines that have been out for the last couple of decades, they've been very specific. Try some over the counter therapies. And when they don't work, go to anorectal manometry, not radiopaque marker testing looking for transit, not defecography looking for anatomy, not a colonoscopy unless there are alarm signs or symptoms, because without those, the pretest probability of finding a lesion in the colon is very low. Obviously, you should do it if you're age appropriate for screening. But anorectal manometry, going back to that idea of if you got a tube and gravity's pushing things down or laxatives are pushing things down and the pelvic floor doesn't open and the door doesn't open, nothing's going to go anywhere. So it is in most cases the first tool in my armamentarium that I go after. And again, that is just following age old guidelines. Fortunately, at Northwestern, we're able to do a lot every week. We do them now at Palos Hospital. We do them up in Grays Lake. So we have multiple facilities. I like to have that data, especially in refractory patients, because if they fail physical therapy or they failed physical therapy before, at the end of the day, I want to compare apples to apples. Where don't I do it? To your point, when a patient comes in and says, I just want to get a physical therapy assessment, can we do this? Absolutely. This is part of the reason why I ask everybody about trauma. If a person has trauma, especially sexual trauma, this is an invasive procedure. We put a catheter in the bottom, we blow up balloons, we have them try to pass balloons on a toilet. This can reactivate trauma. So I want people to be aware of the study and how it works. So in some of these patients, I will absolutely defer anorectal manometry, but in many cases, they may also not be ready for invasive pelvic floor physical therapy, which can be intrarectal or intravaginal. And I'll then defer these patients to my brain gut behavioral therapist to deal with the underlying trauma issues and those sorts of things. So it comes down to a little bit of patient comfort. I do walk through the test. I will tell you that when I talk about anorectal manometry, I give people handouts. I bring up images of the catheter on the computer. I show them images of the actual manometry tracings. I explain every part of what's going to be done before I'm going to refer them for the procedure so they have a good knowledge of what's going on. And in that case, most people are pretty tolerant of it. There are those people, to your point, that will never do it and just want the physical therapy referral. I'm happy to do that as well. It just makes it more difficult if they fail physical therapy to know if it was a failure of the therapy itself, if they're refractory to physical therapy, or if there's something else going on that I should be addressing at that point.
Those are all fantastic points. Sometimes patients are limited because of where they live, also some of the
Of
rural
course.
areas. And fortunately, at least at our center, and this is a tip for all the gastroenterologists out there, if you actually come up with a list of different physical therapists that specialize in pelvic floor physical therapy with biofeedback, and hand it to the patient based on geographic area and list all the geographic area. I think that's super helpful for patients so that they can find someone that you trust close to where they live.
So you're absolutely right, Ben. We have a list and you want to find somebody close to home to make it easier. One other thing for our practicing gastroenterologists, you make a very good point that just jarred my memory. There's a device out there that's FDA approved called the rectal expulsion device or RED device that we're trialing at Northwestern. It is the closest we can get to a balloon expulsion test. It has been validated in clinical trials. It is a one time disposable use. And we've always said if you could have one test to assess the pelvic floor, what would it be? It would be the balloon expulsion test. This is something that the average practitioner, anybody in the country, can use. You can get these devices, have the patient sit on a toilet, blow up the expulsion device, and see if they can pass it. Really easy way in your clinical practice, quick way to determine whether or not you think there's pelvic floor dysfunction.
Thanks for bringing that up. That's awesome. So when do you start thinking about motility orders and how do you work up these patients? And do you actually still order SITS markers testing at any point?
So I don't order SITS marks up front because we're testing transit. And the literature has shown that if you have a pelvic floor problem, i.e., if the door doesn't work, about half of these individuals will have a delay in transit. It could be a negative feedback loop. It could be the rectum and the pelvic floor saying, hey, I'm full. There's no more storage space down here. So whatever's coming down, keep it up higher. So when do I order radiopaque marker testing? When there's no evidence of pelvic floor dysfunction. Then I want to look for isolated slow transit. When somebody has had evidence of pelvic floor dysfunction, done the pelvic floor physical therapy biofeedback, shown that they have improved and corrected the pelvic floor problems, and still have symptoms. Those are the two areas where I look for isolated slow transit constipation. And those are the times that I'll do the radiopaque marker test. Now, I know a lot of my colleagues will disagree with me on this one. The test, the way it's supposed to be done, is off of medications. Hold your medications for 3 days before the procedure, specifically laxatives, prokinetics. Stay off them during the test. That is 8 days. The vast majority of my patients would be miserable. I do this a different way. I do it on medications because at that point, my question is not, do you have a delay in transit? My question is, do you have a delay in transit and is your medication not working? Because if your medication is not working and I validated that with this test, then I'm going to go to a different medication. If none of the medications work and your pelvic floor works, that's when we start talking about potential surgical interventions like colectomies.
Thanks for going over that too. So do you ever order a smart pill motility capsule?
I do. And I use it for people that have both upper and lower GI symptoms. When they're coming in complaining of abdominal pain, nausea, vomiting, bloating, distension, constipation, I will assess whole gut dysmotility. If they have one part of their GI tract that's been assessed in the past by gastric emptying study or whole gut scintigraphy or radiopaque marker testing, and I want to know about the other parts of the GI tract, I will do that as well. In the vast majority of the cases, when I'm seeing somebody with constipation, when do I care about upper GI motility? When they're complaining about bloating, distension, and fullness as primary issues, when somebody is considering doing a resection or a colectomy, I want to know that the upper GI tract works because if there's delays in the upper GI tract, that may explain some of their symptoms as well, and that needs to be addressed.
Great. Okay, so let's talk about a different kind of capsule. And I've been seeing this at our national conferences like DDW and hearing a couple of physicians talk about their experience. But I'm super intrigued about this new vibrating capsule for chronic constipation. What's been your experience so far using Vibrant, which is a vibrating capsule to help with constipation?
So, truth in advertising for your audience, I am a consultant and an advisor for Vibrant, but also many of the pharmaceutical companies and over the counters we talked about before. I've been working with Vibrant for a long time. We just published a paper in CGH looking at the long term effects of Vibrant. It is shown to improve complete spontaneous bowel movement frequency, reduce straining, and improve stool texture. But I think more importantly for me, from a quality of life perspective, it also reduces toileting time. So now we have multiple pieces of literature that show that it works, that it's safe, it's effective long term. I think there are a couple of benefits to using Vibrant. Number one, its side effect profile. Part of the problem that we all have as practitioners is when we give people a laxative or a prescription medication, they develop diarrhea. The diarrhea rates with Vibrant are less than 1%. So that's something I don't worry about. Number two, it gives me an alternative therapy. As I mentioned earlier, we've all heard this. I don't want to take a laxative. I don't want to be dependent on a laxative. I don't want to use a medication. What else you got? This is a capsule that you take 5 times a week. You take it before bed. It activates about 14 hours later, and it vibrates with the exact same pattern that the colon usually contracts with during high amplitude propagative contractions. So it mimics the circadian rhythms of the colon. And so it has a physiologic mechanism that we understand. I think this is a very nice, non-pharmaceutical intervention that people can try. And I have had success in both people who have what I call primary constipation, where they tried nothing else, or quaternary constipation, where they tried everything else and failed it. So something that I think everybody should consider adding to their armamentarium for treating chronic constipation.
And that's really cool technology.
It's really nice. Mhm.
So, in the field of IBS constipation, I recently learned about an online gut directed hypnotherapy through platforms such as Nerva. Could you tell us about some alternatives to medications, particularly for IBS constipation patients, that you find
Sure.
helpful?
So we certainly have Nerva. Again, as you mentioned, this is a gut-directed hypnosis that was developed by the Monash Group in Australia. We had a couple of other CBT gut-directed hypnosis programs. They have unfortunately fallen to the wayside or gone out of business. She also mentioned that Nerva has a CBT component to it as well. These are very good. Brain gut behavioral therapies have been shown to be subtype agnostic when it comes to irritable bowel syndrome, very useful. Nerva can be obtained without a prescription, so a patient can go directly to a website and get it. I want to stress one caveat. Anybody that has a history of PTSD or a dissociative disorder should be very careful if they're doing gut directed hypnosis because gut directed hypnosis can reactivate trauma. So if you're thinking about using this and you have one of those issues, please talk to your practitioners before you engage in that platform. What other things can people think about if they're refractory? There are devices that do abdominal massage. These seem to work best for people with neurogenic bowel dysfunction, people with spinal cord injuries, or birth defects like spina bifida or cerebral palsy. It's a device you can put on your belly, and like a massager, it will go from the descending colon to the ascending colon over and over again. You do this a few minutes a day, and it's been shown to improve bowel parameters and quality of life. There are other people that are looking at acupuncture, acupressure. We do not have good data in the United States right now. Most of the literature comes out of China. The studies are low to very low quality, but I've had patients who have responded very well to acupuncture, acupressure, and it's pretty harmless. And there are other people that are looking into transauricular vagal nerve stimulation, which may have some benefits as well. So there are some non pharma interventions that we're starting to look at that could be potentially very effective. We also mentioned earlier about changing your positioning on the toilet. You don't necessarily need to get a squatty potty. I think it's expensive. You can use an old step stool or a bunch of old textbooks as long as your knees are higher than your hips and your knees are out to the length or the level of your shoulders. Some clinical trials out of Michigan shown that they can actually improve bowel parameters in about 1 out of every 6 individuals who show initially pelvic floor dysfunction. So, some very simple things that we can use to potentially make things better.
That's great. Could you tell us a little bit about any exciting current clinical research projects that you're working on that you want to share?
Yeah, so I'm trying to look at a couple of different things in the pelvic floor spectrum. You mentioned the vibrating capsule working for people with chronic constipation. My thought is this: when you treat a neurogenic bowel patients, you have to do a couple of different things. It's called timed voiding. And after a person eats, you start with abdominal massage. Then you have to stick a finger in the rectum and push circumferentially around the rectum for 20 to 30 seconds. Then you put in a little Bisacodyl suppository, and the patient sits on the toilet and waits to poop. The body can relearn this process. I see a lot of patients who come to me with a chief complaint of, can we talk about an ostomy? Because I'm an adult now and I don't want my mom or my brother or my sister or my wife to stick their finger into my rectum every day. It's just not comfortable. And then have to stick this suppository in there. One of the thoughts is that the vibrating capsule can be activated in any period of time. So if we took the vibrating capsule, we activated it, and 30 seconds later it started to vibrate, that may actually signal the rectum to signal the brain that it's time to poop and could get rid of some of the invasive nature of what people have to do. The nice thing about the vibrating capsule is right now it has one cycle. It's set up in everybody the same way. Moving forward, the goal is precision medicine. If we can figure out what cycles work for what individuals, it may work even better. So we're doing some playing with that. Like I said a little bit earlier, my colleagues at Michigan showed that you can actually improve bowel mechanics and parameters by putting somebody on a posture modifying device. I talked to my pelvic floor physical therapist, and they think the posture modifying devices we have are great, but yoga blocks may work better because you don't want to use the same stroke for different folks. So you can actually tailor the yoga blocks to the correct positioning for these individuals, and that may improve outcomes as well. So we're doing a little trial comparing some of these modalities. And in the IBS space, we are now looking at some newer antispasmodics for treating irritable bowel syndrome. Some better data out of Europe. If you look at the ACG guideline, we recommended or suggested against using antispasmodics available in the US because they're just not that good. But there's data supporting antispasmodics outside the United States. We're looking at some of those. And we're looking at also some early trials looking at bile acid binding agents as well for IBSD. So some new things coming down the pipeline. I'm not involved in these, but some things that I've heard about are also the GLP-1s for treating IBS, which could be fascinating if you think about all the
Wow.
things that they can do.
Thanks for going over some of your exciting research. That's really awesome. You mentioned Michigan a couple of times just now. So we're so lucky to have our new ACG president, American College of Gastroenterology president, William Che from the University of Michigan, helping us to advocate for patients nationally. And I know that you trained with Dr. Che during your gastroenterology fellowship. Could you share with us a favorite clinical pearl about constipation or IBS that Dr. Che taught you?
Yeah, I will praise Bill's laurels. He was my mentor when I was at Michigan many a year ago, not to age any of us. He is still a very close mentor and friend. I think the best thing Bill taught me was not the nuts and bolts, give lax, give Miralax, then give this, then give that. The best thing that Bill taught me was that every person is different. And it is not a one size fits all process when it comes to constipation. And for one individual, frequency of bowel movements means nothing. 2 versus 4 bowel movements a week means absolutely nothing to them. So we really have to talk to these patients. So those patients, it may be, I'm strapped to my toilet. I never leave my house. My social life is destroyed. Help me. We don't do a good enough job looking at quality of life. And that's something that I think Bill does a great job of. He looks at a person as a global 360 individual and he treats them from an interdisciplinary, integrative perspective. I think one of the best papers that was published in the last couple of years was his paper on how to use integrative medicine, medication plus behavioral medicine plus dietetics to get patients the best outcome, but having to listen to the patient and hear what they want. Some people don't want to change their diet. Some people don't believe in behavioral medicine. Some people don't want to use laxatives. Fine. Help the patient develop the right treatment protocol for themselves. Bill had the Michigan Bowel Control Program before I left Michigan. I used that to develop the interdisciplinary bowel control program at Northwestern. I learned that from him. I brought that to Northwestern. And to this day, I still practice what he taught me, which is, again, I'll say the exact same thing. Treat every individual as an entity unto himself or herself. You can't have the same intervention for everybody. It will never work.
Well, thank you, Dr. Brenner, for joining us on the podcast today. It's been so much fun hearing some of your advice about these different clinical scenarios and learning so much from a key thought leader in our field. And I know that you help so many of our most difficult to treat patients. We really appreciate you joining us today in Medscape.
You are too kind. Thank you. You do exactly the same thing. I know that for a fact. So I appreciate everything you're doing out in the community at USC. And again, it's just been my honor and privilege to be a part of this today. So thank you very much for the opportunity.
Okay. Let's go have fun in clinic this afternoon.
Thanks.